Hello, good evening, everybody, and welcome to this excellent webinar on interpreting CPAP telemonitoring data. My name is Mike McEwen. I'm the Managing Director of CFAM UK. We have two fantastic speakers for you this evening. I'd like to introduce the first speaker, who is Professor Jean-Louis Pepin. He's Professor of Clinical Physiology at Grenoble-Alpes University. He's Vice Dean of the Medicine Research Department. He's involved in ASADA, and he in the expertise global ranking of experts, he ranks number 3, but I think he may well be a little higher than that. I'd also like to introduce Dr. Kabir Sabil, who is a PhD in respiratory physiology. He started life as an engineer. He spent many years in research and development roles in industry and is a guest lecturer at the Edinburgh Sleep Department course. He is an expert in clinical validation, and he's been working with us at CFAM. So the only thing I would like to say to you is that there will be the opportunity to ask questions. So please, through the talk, if you could make a note of questions in the question and answer part of the system. So over to you, Professor Pepin.
Thank you very much for the introduction, Mike, and very pleased to share some time with UK colleagues. I will try to share my presentation. Can you see my screen?
Yes, we can.
And my pointer. So the title of the presentation is, the goal of the presentation is to demonstrate the interest of using on routine practice CPAP telemonitoring. This is offering new management pathways for follow-up of CPAP-treated patients. You can have a quick look of my links of interest. Today it's mainly related to CFAM. And we will start with the general context of OSA. We know that people suffering from sleep apnea, this is not only obstruction of the upper airway. These people are exhibiting multimorbidity, and they are at greatest risk of poor outcomes and early mortality. They have several complications, including cardiovascular comorbidities, metabolic comorbidities, and also alteration in cognition and daytime sleepiness. We have the chance to have available some CPAP device telemonitoring platform. We have hundreds of millions of patients worldwide, but the true potential is unexploited. The CPAP machine actually is a connected device providing every night data on CPAP adherence, residual HI, leaks, etc. And we have an access to individual data daily. It is this access is available not only to healthcare providers, but also to home care providers, physicians, and also for the patients. And we have millions of CPAP-treated patients. For example, in France, currently, we have nearly 2 million patients with OSA treated by CPAP. This is a population with a high level of heterogeneity, and we have some challenges. We have low adherence on the long term. We have high CPAP termination rates, and we have CPAP failure in approximately 10% of the patient. So we need to improve some new management pathway, including risk stratification, to identify the phenotypes with a risk of low adherence and CPAP termination, early identification of CPAP failure, and also characterization of progression of comorbidities. And to do that, we need coordination and multidisciplinary teams, but also visualization dashboard, including the routine use of CPAP telemonitoring software and platforms. we will see that with this information, we can detect CPAP treatment failure, high or variable residual RHI, early identification of CPAP failure, and also we need to put together information from different sources to interpret this data by combining clinical data and CPAP telemonitoring data. The first example of this is the impact of mask changes. When you are a CPAP-treated patient, you have every year at least 1 or 2 mask changes, and this can impact residual events under treatment. This is an example of what we can get from a CPAP telemonitoring platform. You have the days, you have the night, you have residual RHI, you have some patient with very stable, normal residual RHI. You have one patient like that with a relatively low increase in residual RHI and also a variation from one night to another. And you can see this patient with, if you only look on the mean RHI, you have, for example, 10, but some nights you have normal residual RHI, and some nights you have very high residual RHI, and this is reflecting CPAP failure and probably unstable clinical condition. And mask, the type of mask can be of importance. We know that facial mask is associated with a reduction in the size of the upper airway compared to nasal mask because the transmission of positive pressure to the mouth is reducing the impact of CPAP pressure. And you can see a very nice example of the use of visualization tools from the CPAP telemonitoring platform. The same patient using a nasal mask. You have normal residual RHI. There is a change in the mask moving to a facial mask, and immediately you can see an increase in the number of residual events and also in variability from one night to another. And when you are returning to the nasal mask, you have a normalization. So you can immediately identify the impact of mask changes using CPAP telemonitoring platform, and you can provide early intervention. And we are now developing some artificial intelligence algorithm for the whole population on CPAP follow-up platform. You have some synthetic controls, and for a given patient, you have an expected RHI over time. And at this step, you can see an increase, an abrupt increase in RHI, and it is associated with mask change. And we are currently developing some smartphone application to provide this information to the home care providers, to the physicians, and also to the patient. So in this case, you have an increase in residual RHI, you have a decrease in CPAP adherence, you have no variation in leaks, and this is related with a mask change alert moving from nasal to oronasal mask. So this is a clear example of the interest of CPAP telemonitoring platform for daily routine management of patients CPAP treated for OSA. Another example is early detection of treatment failure. So there are some situations when you are treating an OSA patient with CPAP. In some situations, you have emergent central sleep apnea, or you have persistent central sleep apnea. And this is not a rare situation. This is occurring in approximately 10% of the patient. This is a big data analysis in more than 133,000 patients with OSA. They are starting CPAP at this point. You have the first 90 days. You have the majority of the patient with normalization of residual RHI, and you have population with an increase in central sleep apnea, what we call emergent central sleep apnea, or a population with persistent central sleep apnea. And this is an important information because this is associated with a higher risk of CPAP termination. So if you can identify early after CPAP initiation this population, you can react and change the treatment. This is an individual example. This patient is exhibiting persistent central sleep apnea. You can see the number of residual events, it's 25 per hour, and there is a progressive decrease over time of CPAP adherence. When you are shifting this patient to adapted servoventilation, you can treat the central events, normalize the respiratory events, and there is immediately an improvement and a stabilization of adherence with the new device. So early identification of CPAP failure, preventing the decrease in adherence by shifting to adapted servoventilation. Some clinical cases. You can see this patient in the majority of the night, there is a normal residual events. And you have 2 periods with higher residual events, and it was related with right knee prosthesis and left knee prosthesis with opioid intakes for analgesia. Opioid intakes was related to central events, not treated by CPAP. In this case, you have just to reduce the opioid intakes. You have nothing to change in the management of CPAP pressure or nasal mask versus facial mask, etc. You should identify the cause of this transient increase in residual events. A very frequent situation is the comorbid association between insomnia and OSA, what we call COMISA. And you can see in general, there is a good control with CPAP treatment. But when you have acute episode of insomnia, there is an increase in central events explained by the transition between wake and sleep and wake and sleep. And in this situation, the right response is to treat insomnia, try to improve insomnia, to stabilize sleep, and there is nothing to change in the settings of the CPAP device or in the management of the CPAP device. Another example, you can see this patient with very good control of residual events. And at this point, there is an increase in residual events. There is several nights without CPAP usage. Actually, at this point, there was a withdrawal of resynchronization therapy pacemaker owing to an acute infection of the implant. It was associated with a deterioration in cardiac function, and the patient is only seen at the consultation here, and we have lost several months with CPAP failure, lower adherence, because we are not in situation to identify CPAP failure. So if you are using CPAP telemonitoring during your routine consultation, you can have an early identification of this situation. Another example, it is a patient well controlled in terms of residual events, very good adherence, some leaks, but not clinically relevant, and there is an abrupt increase in residual events, essentially central events. You should have central apneas and hypopneas in your report of CPAP telemonitoring, and these central events were associated with periodic breathing and the occurrence of atrial fibrillation. So atrial fibrillation was triggering an increase in the number of central events. We have published a study in a relatively large number of patients, 555, within 1 year follow-up, and when central chain stroke respiration was detected by central events using CPAP telemonitoring. We were in situation to detect acute cardiac failure, atrial fibrillation, uncontrolled hypertension. So CPAP telemonitoring is informing you about serious cardiac events occurring in the follow-up or your OSA patients. A critical point is to put different sources of data together to create a new and richer data set, allowing you as a clinician to interpret this CPAP failure. In our routine practice in Grenoble, we are combining our electronic medical record and the CPAP telemonitoring platform. We have information in our medical record regarding comorbidities, especially cardiovascular comorbidities, but also medication intakes, which is really important, and also the symptoms of the patient. And when we are consulting, the patient have fulfilled the questionnaire at home using an internet link. We are uploading IQ code, and we have all the clinical information available, and this is combined and linked to telemonitoring platforms. And what we have seen, when you have high residual RHI with a huge variability, you have several information. This is the situation of associating comorbidities, heart failure, but also TAA or stroke. This is also associated with some situation increasing obstructive events like alcohol consumption, also facial mask, and we have some population with mental and behavioral disorders taking more hypnotics, benzodiazepine, and also opioids consumption. So you can see these clinical situations are associated with CPAP failure and high residual RHI. And you can only interpret this data from telemonitoring when you have appropriate associated clinical information. So to summarize, again, we have very huge active list of patients to follow. There is a high heterogeneity in this population. We should manage for long-term low adherence and CPAP termination, and also with CPAP failure. And we have seen that to provide good management pathway and good care to this patient, we need to combine the information regarding multimorbidity and risk for increase in central events, the type of mask, the symptoms at baseline. There is a specific phenotype at risk of CPAP failure and the risk of developing central events. Again, I would insist, and Dr. Sabil will provide you some demonstration about the interest of the CFAM software to detect these central events. Central events are a very interesting marker of underlying unstable cardiovascular disease, including heart failure, atrial fibrillation, and stroke. And you need to have visualization dashboard with depicting residual RHI and also CPAP adherence and night-to-night variability of CPAP adherence. We need to develop artificial intelligence techniques, because if you are following 1,000 patients, you cannot every morning have a look on every alert, but we can have some automation of this alert and dedicate the alerts to home care providers, to nurses. Some of the alerts should be managed at the end by physicians, but the majority of the alerts can be managed by nurses or home care providers. And the final view is a new management pathway, including digital medicine. You have the OSA patient, you have the physicians, and you should design a face-to-face or virtual follow-up visit. But to do that and to be very efficient in this follow-up, you should have information from the CPAP telemonitoring platform. You can share this information with the home care providers, and ideally, you can collect patient-reported outcomes through the device or through some smartphone application, and also to associate some digital tools to collect real-world data on the quality of sleep and physical activity. And this is probably the way for the future to have a perfect management of this patient CPAP treated for OSA. So thank you very much, and happy to address the questions at the end of the two presentations. Thank you.
Pepin, I'm gonna upload my presentation and we continue. And as Dr. Pepin just said, we'll go over your questions later after I finish my 15-20 minutes presentation. Hope that everybody sees my slides, and I'm gonna put my pointer and it should be fine. So in this second part of the presentation, we're gonna talk about the importance of CPAP algorithms to detect and report all central events, whether they are apneas or hypopneas. Of course, all machines, all algorithm report all obstructive events anyways. So here are my links of interest, and just like Mike presented me, thank you, Mike, for the presentation. I'm currently also working for CEFAM. So let's look at how reliable actually CPAP algorithms are in the assessment of residual apnea-hypopnea index. In theory, the residual apnea-hypopnea index should be the sum of the obstructive and central apnea indexes and the obstructive and central hypopneas as well. So, but we don't really know in general what do the manufacturers really transmit to us when we get this data, whether it is through the cloud application or to the desktop software. So we can start with this study actually from Alfred Midlet from the Grenoble team, from Jean-Louis Pepin's team, where they looked at, sometimes we come to a point where the patient cannot stand a certain algorithm, and we change the machine and all works for the patient. So what they did is they looked at 69 patients in whom the machine was changed. We went from this device A to one of 3 other devices, okay? And looked at the median residual apnea-hypopnea index for this 69 patients, 14 days before they changed the device and 14 days after the changeover to another brand. And the data showed that there is a significant difference in the median apnea-hypopnea index between machine A or device A and 3 other devices. And device A underestimates by 32% actually the apnea-hypopnea index in this particular study. When we look at just one patient that was having a high residual apnea-hypopnea index for 30 days, and you see it's high, it's varied, and then we change from machine or from device C to device A, we see that the hypopnea index drops to a normal below 10. It could mean two things. One is that this algorithm is favorable to this patient. It corresponds to the patient's OSA phenotype and is well treated and everything is well. But if the patient continue complaining and having all the symptoms, this could also mean that machine A just underestimates the apnea-hypopnea index. And in this particular case, actually, this machine reports central hypopneas, and machine A does not report certain hypopnea. And probably, and Jean-Louis Pepin probably can tell us later, this patient probably was having a lot of central hypopneas. That's why the difference is significant between these two machines after we change the machines. And this is important to know that not all machines report the same event. Not all machines detect the event the same way. Not all machines react to the event detected the same way, even when they're obstructed. Let's look at this other patient now on a CFAM machine, and you see here in these three columns we have the flags, or if you want, the alert for apnea-hypopnea index, leak, or compliance, where the patient is beyond a certain threshold. And when we just look at it like this on the cloud application, all is green. In general, we'll stop here. We don't go any further because we don't have time to go into the details. But if we do, we look at that this patient has an apnea-hypopnea index, residual apnea-hypopnea index of 5.5, so which means all is well. But notice here, the only thing that is reported in the central event is just the apnea index, but not the hypopnea index. And you can see here there is no hypopnea included in this report. However, if we include the hypopneas, and you can see if we include the hypopneas, we're going to be able actually to see that this patient has a very high central hypopnea index of 17. And which brings actually the residual apnea-hypopnea index total with all obstructive events, all central event, apnea-hypopnea. Actually, the residual apnea-hypopnea index is rather 22.6, which is high. And if we just look at the flags, you see that it would be flagged right away, and we would pay more attention to this patient and try to understand what's going on with the patient. So now let's look at this clinical case of a patient that has immersion central sleep apnea. So originally, this is a 58-year-old man presenting symptoms: fatigue, disturbed sleep, daytime sleepiness, and so on and so forth. Medical history of hypertension, obesity with a BMI of 32 kilogram per square meter. Was initially treated for 6 months with CPAP for a severe OSA with an apnea-hypopnea index at diagnosis of 35 events per hour. Initial CPAP sit-in was 9 centimeters of water, 90 percentile, good compliance over 7 hours a day. Residual apnea-hypopnea index less than 5 events per hour, no significant leak. 6 months later, out of the sudden, relapse of fatigue, sleep disturbance, some symptoms came back, and it was noted by the home care provider monitoring the cloud by a cloud application that there is a major increase in residual apnea-hypopnea index. So here's what it looks like in terms of detected events. The patient was treated, and you see here the number of events. Actually, the blue is obstructive, and the red, orange is central. Patient had 95% of the time were less than 5 events per hour, and all of a sudden they started having more residual events. And when you look at actually the statistics and look at the data for the period where the patient was well treated, actually the apnea-hypopnea index is about 1.6. And when it picked up and it started getting higher, you see that the apnea-hypopnea index actually was about 12 events per hour. and see if we look at the details a little bit, you're going to see that patient has a central apnea-hypopnea index of 8, which is a little high than we expect for this patient. Okay. Now, one more thing is when you look at statistics and you have central hypopnea 0, you know that it's impossible. We can't just have 0 events, especially when we have already some central apneas. In this case, where the residual apnea-hypopnea index increase. So if we include the central hypopnea, you see already just from the graph that the patient already had some central hypopneas before. When he was well treated, he was still at 5.4, but there was the index of central apneas was 4 events per hour already. But in reality, actually, the apnea-hypopnea index, the residual apnea-hypopnea index is 28, not 13, with a 23 events per hour that are all central events, with a 14, almost a 15 event per hour of central hypopneas. So when we have a patient like this, in general, we need to look at if these central events have been increasing since there is this emergent central sleep apnea in the patient. There was a recommendation published 4 or 5 years ago by the French Sleep Society on how to monitor actually patient under CPAP, and they propose an algorithm of monitoring that says we have to monitor compliance, leaks, and the apnea-hypopnea index. They gave us some threshold that needs to be respected, and over a period of a slide-in window of 7 days. When we look at, in fact, the last 7 days, we'll see that the apnea-hypopnea index actually is 44 with 38 events per hour, central event per hour. That's very high, which means that this patient, when we have a situation like this, it needs to be taken care of differently. We can't just leave them like that. And you see here your hypopnea, central hypopnea index is 20 events per hour. So when we talk about central event, of course, there are central apneas and central hypopneas. And in fact, we have more hypopneas than apneas, more of a reason that we need to include these central hypopneas in reporting residual events. There was the French Sleep Society published new recommendations on central apnea at the end of 2024. And I want to point this recommendation 21, which says that CPAP devices censoring central event and or with compliance reports censoring central hypopnea should not be used in patients with central event on the initial diagnostic recording. What it says is, if during diagnosis we detect central events, then we can only treat a patient with devices that report all central events, and there are 2 devices in the market today. So once we get the report from the application, from the cloud application, what we have to do, because we don't have that detail, so we have to confirm that the events are indeed central. So we get the SD card and we can read it on the desktop application. We see here this beautiful periodic breathing with crescendo and decrescendo. And we can see it with the apneas here, with the examples of the apneas, the pressure does not respond to this central apneas. And here we have some central hypopneas. Actually, there are 2 other recommendations in certain cases. Here it's so obvious, but in general, we have to do a recording, either a polygraphy or a PSG under CPAP to confirm emergent central sleep apnea. So now that we see that the patient has all of a sudden started having these central apneas, what are the possible causes of these central apneas for this patient? It could be many things. It could be treatment emergent central sleep apnea, but no, because the patient had been well treated for over 6 months, so it can't possibly be treatment emergent. It could be associated comorbidities, like the example that Professor Pepin showed you earlier with this patient with in whom we took out the pacemaker and probably have some heart failure or problems like that. It could be due to treatment, like the patient who had knee surgery and who was under opioids, or it could be related to insomnia. We have different possibilities. When we have an increase in central apneas, there are different possibilities. So one thing that you have to do, you can't just look at the apnea-hypopnea index. Of course, you have to examine other CPAP variables, because is there leaks? Is there anything else as patients drop in their use of the machine? I mean, is the compliance going down, and all that needs to be examined. And one very central thing that is very important, and the key information, is you're going to get it from the patient, because it is the patient who's going to complement whatever data you get from the CPAP softwares. Why do I have to monitor residual apnea-hypopnea index? For many reasons. The first one is so simple. It just means that the treatment is ineffective. It could be emergent central sleep apnea. It could be due to the presence of leak, problems with the mask. You know, when patients have a lot of leaks, leaks are going to disturb the sleep. Patients are going to wake up, and patients that wake up a lot through the night, they will have there is a risk of having some central event. The other thing is when the leaks are beyond the threshold of excessive leaks, the algorithms are not reliable anymore, and they can just make mistakes in detecting false event. And that's true with all algorithms for all machines. That could be a technical problem. It's an electromechanical device, so there could be something with it. The patient dropped it on the floor, we don't know. Weight gain or weight loss, mostly when patients gain weight, especially, we're going to see an increase in apnea-hypopnea index. It's most likely to be obstructive, and because they need more pressure. And when there's a loss of weight, usually it's related to the fitting of the mask. The fitting of the mask needs to be readjusted. Indication of other comorbidities. And one thing for sure, an increased residual apnea-hypopnea index is definitely going to lead to a decrease in compliance, and that's a risk of non-adherence. And like you saw in the patient I showed you earlier, there were days where the patient did not use the machine, because if the symptoms are back, they're not getting the benefit of the treatment, and they're less likely to continue on the treatment. There's this study of flu that was published 7-8 years ago that showed patients with central sleep apnea in comparison to obstructive sleep apnea, whether the central sleep apnea is transient, is persistent, or just an emergent central sleep apnea. These patients have lower compliance, and they're more likely to stop using their CPAP altogether. Okay, and last and not least is this paper that just got published by Professor Pepin. We know this is diagnosis, and you know it starts all at the diagnosis. We know today that the prevalence of central sleep apnea diagnosis is about 5%. So if we record 100 per patient, we're gonna have about 5 patients that have central sleep apnea. So they took PHGs, they scored PHGs at 2,439 PHGs were scored the first time without characterizing central hypopneas. And when they did that, it turned out they got about the same number. 4.6 patients had central sleep apnea, 11 had coexisting, that means mixed central and obstructive, and about 84% with obstructive sleep apnea. Now they took those 2,439 PHG, they rescored them, but this time they characterized hypopneas as obstructive and central. So they separated the hypopnea's careful characterizations into central and obstructive. And it turned out that actually the prevalence of central apnea patients is 4 times as many. So it's about 20%, almost twice as many patients with coexisting central and obstructive, and only 60%. So that means, that shows that why do we have patients that were diagnosed with obstructive apnea probably, and they were not well diagnosed. And then we put them in CPAP, and with this intrathoracic pressure variation, it's going to probably brings this issue with central apnea even more. And the other reason why we need to monitor this patient, and it's very important here when you compare central sleep apnea patient to obstructive sleep apnea, yet they have the same risk of hypertension, but patients with central sleep apnea have a higher risk of coronary heart disease, a higher risk of heart failure, and a higher risk of arrhythmia. These patients have more comorbidities, and they have at a higher risk, so they need to be monitored. And once you put them on CPAP, the best way you can monitor them is through data that we get from the CPAP machine. And the data, whether they're being treated properly or what, is the residual apnea-hypopnea index. So this residual apnea-hypopnea index must include all events if we want our monitoring to be reliable. So if we go back to our example, should central hypopnea be included in the apnea-hypopnea index reported by the machine? I let you answer that question for me. Of course, we should. And in the software, the 2 machines, actually, the 2 devices, the 2 brands that report central hypopneas, they allow you to either include them or not include them. And it's for you and your practice to decide what to do with that. So the take-home message will be that telemonitoring of patients on CPAP therapy is essential for early detection of emergent central sleep apnea. If we let a patient around with emergent central sleep apnea without doing anything else, and without taking care of it differently and properly, we're probably putting them at risk. Patient safety is very important. Failure to distinguish between obstructive and central hypopnea at the time of diagnosis can result in an underestimation of central sleep apnea severity and may lead to misdiagnosis. CPAP devices that censor or fail to report central hypopnea should be avoided in patients presenting with central event during the initial diagnostic sleep study. And one thing that is very important, while telemonitoring alone may not be sufficient because patients might have the answer to what's going on, telemonitoring may not be sufficient to fully manage treatment. It remains an essential tool for identifying potential issues in therapy or patient conditions and prompting timely clinical intervention. And it's going to allow us from prevent us from letting somebody at risk, because patient safety is very important, and the monitoring that is provided by the machines is very important. Thank you very much. Now, what we can do is
we have 4 interesting questions in the Q&A.
Sure. Let me just stop. And we can start with what I'd like to do first, Professor Pepin, is we're gonna go through the questions because we had put some questions on social media first. There's only 5 of them, and we're gonna have a quiz and have you guys. You can just go and click on the screen on the right answer, and we're gonna go through that quiz first, and then we'll go and answer all your questions, and we'll take on a discussion after that. Is that okay? Please use the Q&A to ask your questions. And here is the first question. I'm gonna launch it. Please tell me if you can see it. You have 15 seconds to answer these questions. What are the benefits of using manufacturer software for CPAP monitoring? It helps optimize adherence and adjust treatment. It allows for detailed tracking of patient data. It eliminates the need for in-person consultation. It automatically adjusts the CPAP setting without physician intervention. Okay, we're gonna stop. And we got the answers, and the right answers are A and B. We have 88% of the voters answered right, and 81 for second answer. The right answers are 8 and B. I'm gonna go back, ask the second question. And if you have any questions actually about this, we can discuss it as well. At 20 questions, 20 seconds. What is the main challenges of remote CPAP data monitoring? A, the overwhelming amount of data making interpretation, the ability to detect mask leaks, the lack of variability in data from night to night, the absence of internet access among patients. Good, 22, 23 people, 25 people answered, 26 people. Participation is very good. Okay, can show you the results. And we get 81% people had the right answer. Very good. Question number 3. I'm gonna go back. Second, what monitoring strategy can help differentiate emergent central sleep apnea from persistent central sleep apnea? Continuous analysis of CPAP remote data over time, measuring daytime sleepiness only, measuring data sleepiness only twice. There was a little mistake there. Using only patient-reported symptoms. (17, 22 people. Oh, we got a group of experts here. Very good. 25 out of 25 had the right answer, and the answer is A. Good. Stop. Go to question number 4. What are the possible causes of central apnea, hypopnea on CPAP? Transient adaptation to CPAP, CPAP-induced central sleep apnea, associated comorbidities, insomnia. In this case, you should be able to get at least one right because they're all, the answer is A, B, C, and D, all in the above. Okay, we get to the last question. And I have a little problem with the last question. I don't know if you can vote because I can't see the vote. I can't activate it, sorry. It's okay. I'll ask. We'll go over the last question together. And actually, we can start with this question. Do you see the questions, Jean-Louis? Your microphone is deactivated.
Sorry, you mean the Q&A question?
Yes. No. Question number 5.
No,
I can't
question number 5.
Okay, I'll start with this one. Okay. Residual apnea-hypopnea index should include only obstructive apnea and hypopneas, only central apnea and hypopneas, obstructive apnea and hypopnea, as well as central apnea, obstructive and central apnea and hypopnea. And of course, the residual apnea-hypopnea index should include all obstructive event apneas and hypopneas, all central event apneas and hypopneas. Let's move on to the Q&A questions.
Yes, we have very interesting questions.
Very good. Go ahead, John.
In the Q&A. The first one is from experience, I find that changing the treatment mode from automatic CPAP to fixed pressure CPAP is improving treatment emergent central sleep apnea. This is right, and this is important in some of the patient. When you have emergent central sleep apnea, before moving to adapted servo ventilation, you can try during several weeks to have a fixed pressure, not too high, 8 or 10, because the automatic CPAP pressure, you have variation in pressure, you can generate microarousals, and these microarousals can be associated with central events. So we do not have so many publications on that, but we have the same experience as well. So yes, it is a good decision to start by shifting from automatic CPAP to fixed pressure.
Okay.
So this is for the first question.
I'll read the second one if you want this way, because you're the one who's going to be answering most of them. Is the reported prevalence of central sleep apnea in elderly 34 to 69% with heart failure a cause for concern, and should we be looking more closely for this?
Yes, I think in the elderly population we have more comorbidities, and as you have shown, Dr. Sabil, during some diagnosis PSG, we are underestimating central events because there is a limited number of laboratories scoring central hypopnea at diagnosis. And the prevalence of CSA in elderly is underestimated and can be associated with CPAP failures.
Okay, here is a very debatable question. Should the ERS ASM be pushing for standardization of CPAP algorithms? So this is the, we can ask this every Christmas and hope we're gonna get it. I'll let Professor Pepin answer as a clinician, and I answer from my part of.
Yeah, we would love. But we try to suggest to ATS, ERS, and American Academy of Sleep Medicine to push the standardization. And I hope the webinar was convincing you that we need the same reports from the different CPAP brands, but it's really difficult for some political reasons, and also there are some constraints for the CPAP brands. There are no task force ongoing on the subject, but if we have a lot of feedback from the clinicians and from the key opinion leaders from different countries, yes, it would be the goal.
Well, there are two things. I mean, there are two parts to the question. For CPAP algorithm, it's very complicated. I mean, because the definitions are different, the algorithm functions differently, and it's going to be, in my opinion, very complicated to convince and find a consensus. However, I think that DRS, ASM, whichever sleep society is, should really require that the report be the same, and that what we're reporting be the same. And then whether it's reliable, how we measure it, that's a different story, but I think that's very important. Next question is just after what time scale would treatment emergent CSA start to develop?
Yeah, if you look at the big data publication from EU, I was co-authoring this publication. The start is in the first weeks after CPAP initiation. You have the treatment emergency, say you can detect after 1 month at maximum. And so it's not necessary to wait several months and have CPAP termination or a decrease in adherence before reacting. And this is one of the main message we have tried to present with Dr. Sabil during this symposium. If you are using CPAP telemonitoring, you can have an early detection and the appropriate response. So the time scale is 2 or 3 weeks, and you have to react quickly to identify the cause and treat accordingly.
And if may add, Professor Pepin, it's patient dependent. I mean, obviously a patient that was misdiagnosed, you're gonna see it right away anyway. So in some algorithms, there is a next question. In some algorithms, if some algorithms do not report central events, then could we be missing clinically relevant CSA and perhaps lead to treatment mismanagement?
Absolutely right. This is one of the take-home message from this webinar.
Maybe we're not gonna, well, can we rely on machine data regarding AHI? Some studies demonstrated difference between AHI PSG and AHI sleep. That's
Yes, this is also one of the messages coming from the webinar. If you are not reporting central hypopneas and some central events, you can get some discrepancy between PSG and CPAP report. And also one of the problem difficult to manage is the leaks. Dr. Sabil was telling us that when you have the leaks above unacceptable threshold, the detection of the residual events are not good from the CPAP device.
exactly.
Abdelkebir, if you want to add something.
Also, that's good. Next question is about insomnia. How does it cause CSA? There is a paper with Jean-Paul Jensen's actually on that.
Yeah, it is the same reason that we have discussed before for APAP versus fixed CPAP. When you have sleep instability, you have a lot of microarousals. You are going to decrease your PCO2 and have some ventilatory instability, and then you can get central events. So the main mechanism is instability of sleep, generating instability in ventilation and then central events.
There is a question of a colleague, a friend, Jan Ritori. Recommendation 21, could you give more details? Recommendation, do you want to answer that?
Yeah, you can go ahead.
To make it quick, if during diagnosis the clinician detects central event, then the requirement now is, because if we detect event during diagnosis, chances are patients are going to have central events during treatment, and we need to monitor them. And if we're going to monitor them, we need to use a device that report all central events. Sometimes we get sleep fragmentation with an acceptable AHI less than 10. Is it insomnia? Do we have to rule out other causes?
Insomnia is defined by patient complaints. So sleep fragmentation is not always insomnia, but sleep fragmentation can be associated with fatigue, with daytime sleepiness. So yes, you should rule out other causes, periodic leg movements, pain, for example, etc. So yes, there are needs to find other causes.
Here's the next question. Are all residual events important, or only those that are associated with desaturation?
Yes, The events associated with desaturation are of major importance, but as addressed by the previous question, if these events are including sleep fragmentation, non-refreshing sleep, fatigue, and daytime symptoms, it is significant and relevant for the patient and associated with poor adherence and CPAP termination. So it's not only events associated with desaturation.
There's an interesting question about the change of the mask when we change from nasal to facial mask that generate increase in event, or is the using of facial mask that causes the increase? The one thing that is we have to remember actually that we need more pressure with a full mask that we need with a nasal mask. And there is actually meta-analysis with 13 studies at the end, and it showed that on average we need 2.8 centimeter of water higher with a facial mask. So if we don't review the setting of the pressure, the patient is not going to be getting the right pressure and with the facial mask, and they're going to have more event. I don't know if, John, you want to add something else?
Yeah, absolutely agree. And so sometimes the home care providers, they would improve the leaks, but facial masks usually are not improving leaks. But you need additional pressure, you have an increase in residual events. So the priority in the choice of the mask is nasal mask.
We still have more questions. We'll pick up another 3 or 4, Jean-Louis. Do you think central apneas and central hypopneas could be related to using the wrong type of CPAP mask, such as nasal versus full face mask? I never thought about that.
No, not directly. Actually, the type of mask is mainly related to obstructive events. But if you are increasing the leaks, if you have microarousals related to leaks, in this case, you can generate central events. But in general, the type of mask is mainly associated to obstructive events.
Okay, when central event is recorded on sleep machine, how to be sure the patient is asleep or not awake?
This is a good question. This is a relevant question. But you have the same problem with respiratory polygraphy.
Absolutely.
So yes, this is a fair point.
Well, there is also, we can look at, I mean, those that are experts, you can look at the respiratory rate and the respiratory signal, the flow signal can give us an idea if we're awake or not in general when we're a big expert in analyzing sleep from respiratory signals. Other question, has been the mask altered, not yet available, or I'm not sure if
it is not available yet, but you can ask to CFAM Research and Development to implement the app with the device. No, it's a joke. We plan to develop the app, but it's not available yet.
Are there medical ethical consideration to not reporting or residual event in CPAP device algorithms? That's an interesting question. Now that we have clinical practice recommendations, I mean, if we don't do that, is the clinician okay with that? I don't know, Charlie. What do you think about? It's
I think
a complicated question.
It's not really an ethical consideration. It's a good sense to report all residual events in CPAP device algorithm for the appropriate management of the patients. I would not discuss ethical or not ethical consideration. It's good sense and a good clinical practice.
And we have a couple more and we're done. If patient develops CSA without any known cardiac history, should we be referring to cardiology?
I think the first question you have to ask or to look at is the medication. We have so many medication inducing central sleep apnea, opioids, hypnotics, benzodiazepids, ticagrelor, etc. There is a long list. So if you have absolutely no cardiac history, no abnormalities on physical examination, and you have a normal BNP, you should not systematically refer to a cardiologist. But if you have even very transient or limited symptoms, you can get cardiac failure with preserved ejection fraction. For example, in this case, you should refer to cardiologist, but really have a look on medications. It's a very frequent explanation.
I have a last question again, Jan Rettori, about the recommendation 21. They like this one. What about patients who will develop CSA during treatment? Does this recommendation take that into account? It doesn't matter, I guess.
Yes, agree.
I mean, the good practice today is to report, I mean, any patient, I mean, whether it is emergent or not, we can have central events. And central event, it's not just apneas, it's apneas and hypopneas. So I think it's a good practice to report. And if we're gonna have a consensus one day on the algorithms, what different devices should be reporting, I think it should be this, that the apnea-hypopnea index reported should include all events, whether they are obstructive central apneas or hypopneas. Well, I think we're coming to an end.
Now, we have one question just above. I have noted significant variability in the radial central archive from one night to another. Again, a very practical and interesting question. You know, you have some situation, you can get some variability. Insomnia is an example, but also if you have a patient with atrial fibrillation, the number of central events is related to the burden of atrial fibrillation during the night. So you have some nights free of atrial fibrillation episodes, and you have a quite normal number of residual events. Another night, you have a high burden of atrial fibrillation, and you have a massive amount of central events. This is explaining the variability.
And the other thing is also people that take treatment for one thing or another, I think. And there is a paper that got published not too long ago on, and believe it or not, on positional OSA. There is also, some patients can also have central apneas that are related to the position they sleep in. So it's probably that's good, but it's very rare, but there is a situation like that.
And Dr. Sabil, you have a fan in France. The name is Sandrine Launois.
I saw that. That's good. Well, thank you very much.
Thank you very much.
Thank you guys for being in this symposium and this webinar. Thank you very much. And hope to see you for a webinar. Thank you.
Thank you very much for interaction.
Thank you.